As I understand it, you made $52 million in total compensation in 2022.
We very much support generic drugs.
Free rider syndrome.
I want to peel back the onion here a little bit. How much did Johnson & Johnson benefit financially from the administration's military COVID vaccine mandate?
There's no doubt that patients are going to pay less for our drug Eliquis, or frankly, most of our drugs outside of the U.S. than in the U.S.
This is what this looks like. Sheet after sheet after sheet.
What would your definition of a free market be?
Is that a yes?
Are you looking for the answer now?
Our first witness will be Joaquin Duato, Chairman and CEO of Johnson & Johnson. Mr. Duato has served as Johnson & Johnson's Chairman since 2023 and Chief Executive Officer since 2022. Our next witness will be Robert Davis, Chairman and CEO of Merck. Mr. Davis has served as Merck's Chairman since December 2022 and CEO since 2021. Our third witness will be Chris Boerner, CEO of Bristol Myers Squibb. Dr. Boerner has served as CEO of Bristol Myers Squibb since November 2023. My question to you is a pretty simple one. Will you commit to lowering the price of Keytruda in the United States to the price of Japan?
Well, Senator, I think first I acknowledge the prices in the United States are higher than they are in many of the countries you said, and not for all drugs, but for many drugs, and that's the reality we face. But I think it's also important to point out that you get access in the United States faster and more than anywhere in the world. We have 39 indications for Keytruda across 17 tumor types in the United States. If you look across Europe, it's in the 20s. If you look across Japan, it's in that number or a little bit less.
Let me ask the last question to Mr. Davis. As I understand it, you made $52 million in total compensation in 2022. Will you commit to not accepting a single dollar more in compensation until there is not a single GoFundMe page for Keytruda?
Well, I can tell you at Merck, we are very much sensitive to what's happening with patients. That's why we have very important patient assistance programs. We commented on the fact that we have over 800,000 patients benefiting, where we provide free drug for those who can't afford it, as well as other assistance programs that help with copay and others. So we are very committed as a company to doing what we need to do to try to help alleviate the challenges patients face that you're focusing on, and that's my focus as the CEO.
Will you commit to not accepting a single dollar more in compensation until there is not a single GoFundMe page for Keytruda?
Well, I can tell you at Merck, we are very much sensitive to what's happening with patients. That's why we have very important patient assistance programs. We commented on the fact that we have over 800,000 patients benefiting, where we provide free drug for those who can't afford it, as well as other assistance programs that help with copay and others. So we are very committed as a company to doing what we need to do to try to help alleviate the challenges patients face that you're focusing on, and that's my focus as the CEO.
How are we going to show restraint on the price of some of these new gene therapies, which already is driving up Medicaid? So again, 35% of Medicaid is now pharmaceutical cost. Mr. Boerner, I'll start with you.
Senator, we actually don't work in gene therapy.
Oh, then let me go to
today.
Davis. Mr. Davis?
We actually do not work in gene
Oh, I
therapy.
thought I saw you had a press release that y'all were doing so. You had a vector or something.
No, we're doing some very basic research, but we have nothing in advanced stages.
Mr. Duato?
We do have a gene therapy served for treating inherited retinal diseases, and we support legislation in order to be able to do value-based contracts in the case of gene therapy. So we welcome legislation in order to be able to have value-based contracts.
And that's good. Value-based contracting will be important, but it still doesn't address the opening cost.
Well, the short answer is, as I look at it, one, we very much support generic drugs and biosimilar drugs. I think it's the core of how our system works. We have a period where we're protected, we are able to recoup our investment, and then society benefits in perpetuity beyond that. As we look at life cycle management, we always are asking, are we bringing value to the patient? I'll give you a live example. If you look at Keytruda now, as I mentioned, is in 39 indications across 17 tumor types. It is revolutionizing the care of patients facing cancer. The reality of it is still only 30% of people show overall response. So as great as it is, patients are still suffering. And what we are doing is investing in combination therapies to be able to extend and go beyond that 30%, which means much better benefit and value to the patients that will ultimately use those drugs.
So you don't identify any free rider syndrome today in which the United States is paying higher prices, allowing other nations to receive lower prices?
I agree with you that the prices in the U.S. Are generally higher for medicines, more aligned than what you are describing, as the rest of the healthcare system prices are. The percentage of pharmaceutical expenses over total healthcare expenses in the U.S. is 14%, and that is lower than most of the advanced economies. The real difference is that in the U.S., patients get access to therapy, life-saving therapy, years before they do in the countries that you mentioned.
If the United States were to restrict the prices we paid, would that create a different negotiating dynamic in countries that right now, for instance, are paying 50% of what the United States pays? Would it allow you in your negotiations to get higher prices from other nations that right now are paying far less than the United States?
We believe that price caps are not the way that innovation is going to be fostered. We have worked with the United States State Department and with U.S. embassies around the world to try to reject the price caps that some countries, as the one you mentioned, impose. And we welcome the support of the U.S. government in avoiding that these governments are ultimately imposing price caps on us that are not benefiting their patients neither.
Well, I'm looking at 2022 profits and spending by Johnson & Johnson, and it shows me $11 billion in dividends, $6 billion in stock buybacks, $45 million in executive compensation, and $14 billion in research and development. Can you understand, let me ask you a different question. Can you understand that one of my constituents in Connecticut would look at those numbers and think that you care more about padding the pockets of the folks that work for you and invest in you than in research and development?
Our priority is investing in R&D. We have spent $77 billion since 2016. And yes, we have to pay dividends because it's the only way that the company can remain operational and sustainable. Otherwise, if we are not operational and sustainable, we are not able to fulfill our mission of developing medicine for patients and making them affordable.
Well, I'm looking at 2022 profits and spending by Johnson & Johnson, and it shows me $11 billion in dividends, $6 billion in stock buybacks, $45 million in executive compensation, and $14 billion in research and development. Can you understand, let me ask you a different question. Can you understand that one of my constituents in Connecticut would look at those numbers and think that you care more about padding the pockets of the folks that work for you and invest in you than in research and development?
Our priority is investing in R&D. We have spent $77 billion since 2016. And yes, we have to pay dividends because it's the only way that the company can remain operational and sustainable. Otherwise, if we are not operational and sustainable, we are not able to fulfill our mission of developing medicine for patients and making them affordable.
I want to peel back the onion here a little bit. Today, we're being led to believe that these costs are due to corporate greed. I want to know if we're going to talk about some additional drivers of healthcare costs. When the federal government dumped trillions into various industries during COVID, we upended our markets and drove prices through the roof. When I talk to healthcare folks back in Alabama, labor cost is one huge problem. But there are other costs, including supplies and raw materials. What impact are these having on the drug development and high drug cost?
Certainly, Senator, when we look at the cost basis for us doing what we do as a company, which is to bring forward new medicines for patients, we have to factor in all of those costs. I'll give you an example. In cellular therapy, which is really transforming very late-line hematologic diseases, these are very complex medicines. You're taking patient cells, manufacturing them, and re-engineering them to really target and hone in on cancer cells, and then you re-inject them in the patients. This is really a first-generation technology. Unfortunately, it has very high labor costs, because this is one that's very manual. It's a multi-step process to manufacture these products. Their transportation costs, their raw material costs, all of those factors go into a cost of these first-generation medicines. Now, we're very focused on trying to innovate to get to a second and third generation quickly so we can bring those costs down, not only because it's important for us to be able to funnel additional research into development, but also so that we can bring ultimately the cost down to patients. So they are absolutely a factor, Senator.
How much did Johnson & Johnson benefit financially from the administration's military COVID vaccine mandate? Could you have any kind of guess to that?
Our effort in the COVID vaccine that we collaborated with the government, it was a time of a global emergency, so we thought that as a healthcare company that cares for patients, we needed to collaborate with the U.S. government. That was entirely non-for-profit.
Do you think the soldiers who were expelled from the military was the right thing to do, and should they be reinstated?
I was not aware of this situation, sir. I am not aware of these circumstances, so I cannot comment on that.
Thank you.
There's no doubt that patients are going to pay less for our drug Eliquis, or frankly, most of our drugs outside of the U.S. than in the U.S. That, unfortunately, comes at a fairly significant cost for those patients outside of the U.S. In Canada, patients will wait roughly 3.5 to 4 years to get access to a medicine that is available in the U.S. You see similar sort of stats in virtually every European country and in Japan.
But I want you to speak about rationing care in this country. How do PBMs ration care when they take a drug like Eliquis and don't allow it on their formulary? Does that ever happen?
Senator, I'm glad you raised that point. We have had absolutely that case happen on multiple drugs. We've had it happen on Eliquis. We've had it happen where when we have not been able to reach an agreement with an intermediary on a rebate, that they've taken Eliquis off of formulary. And when that happens, those patients no longer have access to Eliquis, and they have to go on to another branded, or in many cases, they may go on to warfarin, as you say. Eliquis is the #1 product in the oral anticoagulant space.
Okay. So I'm going to sorry to catch. So they have to go back to warfarin, the Coumadin, the drug that I was using in medical school in the 1980s, a drug with significant complications, hassle factor. The patient has to go get blood testing done, maybe twice a week as well. But with your drug, one of the miracle parts of it is A, they don't bleed into their brains anymore, and two, they don't have to go get their blood testing done once a week as well.
We need to know specifically what you're doing to lowering costs so that no one, especially someone who needs a life-saving intervention, a life-saving treatment, is going to be denied that solely because of cost. And I'll start on the left, Mr. Duato, going left to right.
Thank you, Senator Cassidy. We absolutely want to be part of the solution. We understand that copay obligations for U.S. patients are burdensome, and it does create health inequities. What are we doing for that? We have a very extensive patient assistance program that for commercial patients enables them to be able to pay low copays, $5 to $15 per month. We supported more than 1 million patients in 2022 with our copay assistance programs. If a patient is underinsured or not insured, we provide free drug. We gave $3.9 billion in free drug in 2022. But I think we can do more, and we can work together in order to lower out-of-pocket costs for patients, even in Medicare, as you mentioned, because that's a real need that we are committed, all our employees are committed, in order to make sure that our medicines get to the patients that they deserve it.
Do you think it would still be a profit, Mr. Davis, if you added in all the R&D, the $2.6 billion to get it through this system, the apparatus of your company, and you divided all of that out for profitability? Would it still be profitable in most of these other countries?
I have not done that analysis, but I would say that the profitability would be marginal at best.
Can you tell us how many patents have been filed on this medication?
I don't have the exact number. But I would focus you on probably the most important patents, which are the composition of matter patents. In addition to that, we have formulation and manufacturing patents. There is one suite of composition of matter patents that we have, and those are what allow us to continue to have exclusivity.
Well, I don't think it would surprise you to learn that I do know how many patents you currently have. It's 168. This is what this looks like, sheet after sheet after sheet. Patent office records show that not only do you have 168, but half of them relate to the process Merck uses to manufacture the drug, not the way that the drug is used to treat patients. Merck is using patent gimmicks and loopholes to delay other companies from selling lower-cost versions of this medication, all while raising the price of Keytruda in the U.S. year after year.
And I'm very concerned that this disparity between list price and what you actually get paid is a problem. And I don't know why it's a problem or what we can do about it. But do you have PBMs and getting prices and discounts like this in other countries that you compete in? Yes, Mr. Boerner, yeah.
Senator, we do not. This is a unique element of the U.S. healthcare system.
Is that true for you also, Mr.
That
Davis?
is true for us as well.
And Mr. Gatto, is that also true?
This is unique. The inequity that exists in the U.S. is because of that we have higher out-of-pocket costs for patients than anywhere else in the developed world.
How much did your company spend on R&D last year?
Our company spent just over $9 billion last year on R&D.
And then how much did your company spend on stock buybacks, dividends, and executive compensation last year?
I don't have that exact figure, Senator, but
Does $12.7 billion sound right from the HELP study?
That's roughly correct.
If price controls like those in Europe are implemented, how do you see a solution to the balance between affordability and innovation?
Yes. So, Senator, thank you for the question. You know, I would start with, at Merck, and what are the principles we apply when we think about how we price drugs? Because I think it also gets to some of the other questions that have been asked about what stops you from just raising your price. And I can tell you that as a company, and this goes back to the core of who we are over 130 years and is truly the purpose we live by, and that is we look at several elements. We look at what is the benefit to the patient, but equally we do look at what is the benefit or the cost to the system. We look at access and affordability, and I can tell you, for instance, when we launched Keytruda, we launched at parity to market price, even though we knew we had a better product, in part because we wanted to ensure access. And so we look at all of that, and then we look at what does it take to absorb the cost of all the failed drugs. We know 90% of all drugs we will bring into the clinic fail. The reality of it is the drugs that make it have to fund that failure. In the case of Merck, it's just interesting, I think, to point out, since 2014, the minority of drugs we have launched have actually even returned their cost of R&D. The minority. The majority have not returned their cost of R&D. So it means that when you do get the rare drug that succeeds, it has to help cover that.
How much would acute myeloid leukemia patient, how much would that patient pay every month for your drug, Adifa, the cancer treatment? That if, let's say, they had a 20% coinsurance responsibility?
Senator, I don't have that exact figure off the top of my head. What I can say is that for most of our oral oncologic drugs, we're able, as on the commercial side, to bring copays down to a very low amount and in many cases to zero. Now, to a point that was raised earlier, we have to do more to make that more widely available and an easier process to actually get into those programs, and we're working on that. We've been doing that since I became CEO in November, and that's something we're committed to. And again, I'd like to be able to provide that same benefit on the Medicare side.
What would your definition of a free market be?
One where you are able to bring goods, and if those goods bring value and the system sees value in them, you're able to bring those at a value you think is fair and reasonable and negotiate with the other sides in a world where you have free competition.
So right there you said negotiate. Most free markets are typified by this. And I'd like you all to listen to this because I think the big challenge, if I were in your seat running your companies, is that it's not a free market. A free market means you've got a lot of choices, you've got vibrant competition, no barriers to entry, and you've got an engaged consumer. Now, do any of those apply to your business?
I think all of those apply, but I think one thing we need to understand in the way our business functions, for a period of time, we have exclusivity. That's during the patent protection period. Thereafter, and in that period, we must reap a return on the investments we make to fund the R&D we do. Thereafter, drugs are freely available, and there is total competition in that space.
But yet you would sue to keep transparency in terms of what the consumer price would be or the list price. Or you do things like tweak patents. That doesn't happen anywhere else. And you're not alone there. Hospitals and insurance companies do all this stuff behind closed doors as well.
I can assure you that the 50,000 employees of Johnson & Johnson in the U.S. wake up every day thinking what they can do for patients. And I can represent proudly that sentiment. What can we do to address the real inequity that exists in the U.S., which is that seniors and patients that need the medicines the most pay higher out-of-pocket costs? In my view, that's the real problem. There are other things that are positive in the U.S. healthcare system, like the access to breakthrough cutting-edge treatments earlier than any other country in the world, but it's true, we have a real inequity there. I think we have to work together in order to address that inequity, and there's multiple ways that we can work on that. One is to make sure that...
Just give me one, because I want to make sure I've got a couple more questions.
One is to make sure that the discounts and rebates, we pay $39 billion in 2022, that we pay to the middlemen are passed to the patients so we can lower the out-of-pocket costs.
If we were to pass a meaningful PBM reform bill, and much of the conversation today has been about this weird difference between list prices and actual net prices, if we were able to pass a meaningful PBM reform bill, what would that do to the cost that American patients are paying out of pocket for pharmaceuticals? Please, and I'll ask each of you to address that. Mr. Duato.
Thank you, Senator, and thank you for recognizing the value for patients of pharmaceutical innovation. If we were able to pass meaningful reform, meaning a reform that would delink the revenues of the PBMs and insurance companies from the list price, and that would pass rebates and discounts to the patients, I would anticipate two things. One, it would affect list prices. Two, it would significantly reduce the out-of-pocket cost for the patient. So I welcome the bipartisan efforts of this committee to go through PBM reform. It's a linchpin of lowering the cost for patients.
Mr. Davis.
Yes, I also believe that the provisions that are in the bill, at least some of the big ones around transparency and also delinking, are definitely steps in the right direction. I think we need them. They're a lot of what we've all been focusing on in our testimony and in the question and answers. And I do think it can benefit patients if we move in that direction. So I'm very supportive of what you're trying to do.
Mr. Boerner.
Senator, if we could do that and we could reduce the significant amount that we are paying in rebates to intermediaries who are not passing those rebates on to lower out-of-pocket costs, speaking on behalf of Bristol Myers Squibb, we could work almost immediately to begin to bring down list prices, and I would welcome the opportunity to work with this committee to do that.
Yes or no, will you commit to not blocking other drug makers from entering the market when the primary patent on Keytruda expires?
Well, Senator, at Merck, and we do believe that biosimilar competition and generic competition is core to the system. We need the patent protection, and then we need a robust biosimilar and generic market. And I can tell you that when the composition of matter patents expire on our drug Keytruda, I fully expect, and I will not try to stop, a biosimilar IV version of Keytruda coming onto the marketplace.
Is that a yes?
That's a yes.
I appreciate that. Mr. Boerner, yes or no, will you commit to not blocking other drug makers from entering the market when your primary patent on Eliquis expires?
Senator, we have a number of patents on Eliquis, and we have certainly anticipated that when the patents that are most relevant for that product expire, we will have generic competition, in this case not biosimilar, but generic competition, and that would be around 2028.
When the primary patent expires on Eliquis, will you commit to not blocking other drug makers from entering the market?
Senator, I'm not a patent attorney, so I'm not entirely...
You're the CEO.
Senator, I would say that when the most important and most relevant patents expire on Eliquis, we will welcome generic competition.
So is that a yes or a no?
That's a yes, Senator.
Do you think that's what Judge Merck intended when he had that high-minded philosophy, which he used to describe Merck's?
In 17 seconds.
Are you looking for the answer now?
Yes.
Okay. Well, I would say the quote was, medicine is for the patients, not for the profits. But so long as we've remembered that, the profits have always followed. And what he was capturing was if you focus on bringing new medicines to benefit patients today and make sure you have an investment and a return to bring medicines for the future, which we are a biopharmaceutical research company, research is who we are, innovation is the lifeblood of our company, then we can deliver for the mission to the patients. And I can tell you at Merck, and I'm very proud of this, we always put patients at the center. And we always look at ways to do that. And that will continue to be what we do. So I do think actually what we're doing is consistent because it allows us to be sustainable for the long term, to deliver for patients into the future.
I just think it's turned into medicine for the shareholders and not medicine for the people like my father.